Welcome to Human School. I'm Dr. Patil Armenian, and each episode I'll share some of my personal stories, interview inspiring people, and offer tools to help you with the mission of being a human on Earth. Hello, and welcome to Human School, Dr. Gül Dölen.
Hello, nice to be here.
Now, Dr. Dölen, or Gül as I will be calling her from this moment on, because she is my friend, is a professor of neuroscience and psychology at UC Berkeley, adjunct professor of neuroscience and neurology at the Johns Hopkins School of Medicine, director of the PHATHOM project, and really, I think, one of the most cutting-edge researchers in psychedelics today.
Aw, that's a nice intro. Thanks.
Yeah, I mean, it's a nice intro, but it's true because your work has been so important and you've made so many discoveries which really show that psychedelics could be the master key for unlocking critical periods in the brain. And you've also shown that this is not just how psychedelics work, but this can expand the conditions psychedelics can treat, right? Like out of psychiatry and into other fields of medicine as well. And you do this through work with mouse, octopus, human subjects. You know, we're just going through a lot of different animals. And let me know, what am I missing?
No, that's great. That is what we do. We're taking the big umbrella approach. And, once we made this discovery about critical periods, it's funny because when I talk about this research at psychedelics conferences, people are excited because it's like, oh, it's an explanation for psychedelics. But in neuroscience conferences, the critical period thing is the bigger deal, right? Like we have been looking for master keys for unlocking critical periods for like 100 years, right? We've only been looking for the mechanisms of psychedelics for like 40 or 50, right? So it's just a different magnitude. And so when we made this discovery, first I wasn't sure what to make of it. And then I was afraid like some of the mechanistic details that we found weren't going to sit well with some of the electrophysiologists. And then I had to go and like apologize to people who I had doubted when I was a graduate student because, we had this rivalry between Harvard and MIT where there was this Harvard professor who was like gunning to try and find master keys for unlocking critical periods. And my lab at MIT, we were like, no, that'll never happen. Anything that can do that would cause seizure or memory loss or structural instability in the brain. So then when we discovered that psychedelics were the master keys, I actually had to go to get a talk at Harvard and apologize to that professor because I was like, oopsie, you were right.
But actually, that's one of the beautiful parts about science that I think non-scientists sometimes either forget or don't know about is that we will find new things and then evolve what we're thinking. And it's okay to go back to where you were before and say, hey, look, I understand now and I'm adding to the field.
Yeah. And I say, if you're going to be wrong and be spectacularly wrong, the best way of that is for you to figure that out yourself. So like if I was wrong about the critical period thing, I'm glad I'm the one who figured that out. So it makes it much easier to swallow the wrongness. Yeah.
Definitely.
So, anyway.
Now, today we're talking mostly about some of the psychedelics news that's been going on in the last couple of weeks with the executive order from the president and now the FDA issuing 3 priority vouchers for expedited approvals for psychedelic assisted therapies. Now, as a researcher actively working in these studies, what does this mean to you? And do you think it will help or hinder the research?
Yeah, I mean, overall, I would say very excited. And yes, it will help the research. For me, the executive order is sort of guidance, but it's not specific. Like there's very little specific information about how this is going to play out. There was, a promise of money, a promise to expedite things, a promise to prioritize. But in terms of trying to know how this is going to affect directly what my lab and what the projects that I'm working on or how that are going to be impacted by this, it's hard to say based just on the executive order. But what I will say is that this is a big shift in the public discourse. And I think that it was possible because psychedelics are, one of the only bipartisan issues, right? Psychedelics are, I think, increasingly seen as this is a medicine. This is useful for people who are suffering from mental illness, addiction. This crisis affects blue states, it affects red states. And so, I think there's 40 years of background legwork that has led up to this moment. But I think that the Trump administration did absolutely the right thing to say, okay, it's time to end the drug war. It's time to take these medicines seriously. And I'm really excited that they did that.
Yeah, I mean, it's a really bold move, but I like the way you put it that there's 40 years of work behind this. And, I always like to say that mental health issues and addiction issues are equal opportunity offenders. I think because they affect everyone in every part of the socioeconomic strata, every race, every type of person is affected by these things. And so that's why it is completely, in my mind, apolitical and bipartisan. It's every state, everyone's affected. And so it is nice to see that we can move forward in a positive way.
Yep. Yep. I think that that's true. And I think that these are the kinds of radical changes that take some time for people to let it sort of sink in. Like just even in the course of my own career, I remember when I first started my lab and I was applying for grants. So this is, 12 years ago. I remember applying for a grant and someone at the NIH basically said, you need to change this whole grant because there is no way that psychedelics will ever be given as medicines. You need to prioritize the oxytocin work and, intranasal oxytocin. That's what's going to end up in human patients. Psychedelics will never end up in human patients, right? And it's amazing how much different that is, even in 12 years, right? Now we're sort of, this is seen as this big hope, and a lot more people who are establishment type of scientists, establishment clinicians are coming around to seeing it this way.
That's so interesting you bring that up, because how difficult was it to get your first grant for something involving psychedelics as therapy?
I applied 17 times and got rejected. And the reason I kept getting rejected is because the NIH is very conservative in the way that they fund research. And so for wild ideas like I found the master keys for unlocking critical periods, they don't believe it until basically I didn't get the grants until the paper had already been accepted at Nature, right? So it had to already get the stamp of approval from, the premier journal of science, right? And only then were they willing to take the risk to fund the project. And so,
17 times?
Yeah.
Okay, just everybody, forget even like the topic of what we're talking about. See, if you're passionate about something, you will take those 17 rejections and get the 18th one to be the acceptance. Like I would have already given up.
Yeah. Well, honestly, I was very close to giving up at one point, but we had money from private foundations, which sort of are a little bit more risk tolerant than the NIH. And then as I was sort of running out of that money and starting to think, oh God, I'm never going to make it in science. I'm just not, like my ideas are too wild. My projects, the things that I want to work on are just not mainstream enough. And I thought, okay, well, I'm going to have to pack it up. I've got just a little bit of money left. I'm going to do one wild and crazy experiment just for fun, just because I'm curious, because that's why we all became scientists, to be curious, right? And so I had this opportunity to give ecstasy or MDMA to an octopus. And I was like, I'm just going to do it and see what happens. And then, it was amazing. We got a huge result. And I was like, all right, if I have to close up the lab by the end of the year, at least I got to do this one wild experiment that changed the way that I understand the brain and was a paradigm shift in the way that we understand how to model things in different species. And so, yeah, and so that came out in, I think it was in September. And a few months later, I got the first two NIH grants, the big ones. So it sort of held me over until I was able to get those grants.
Amazing.
Yeah.
And for the people listening who don't know what happened to the octopus when you gave MDMA, what happened?
Yeah, so octopuses are viciously asocial animals. So normally, if you put two of them in the same tank together, they will kill each other. But we wanted to know what would happen with MDMA, which is this psychedelic drug that has prosocial properties in humans and rats and mice. And so we, adapted the behavioral assay that we used to test that, and we put them in a tank with 3 chambers. And one chamber has another octopus underneath an inverted flower pot. The other side has a little toy. In this case, it was like a little Star Wars figurine under the other flower pot. And then we just measured how much time they spent in each of the chambers. And before the MDMA, they spent almost all of their time in the chamber containing the toy as far away from the other octopus as possible. And then when we gave them MDMA, the situation completely reversed. So now they spent most of their time in the side that had the other octopus, which is exactly what mice do and what rats do and
humans.
And humans do. So, right. Yeah. So it's sort of amazing. And the reason that that's so amazing is because when I was doing those experiments, it was fashionable, and I mean, still a little bit fashionable, to say things like, well, you can't study the interesting part of psychedelics in animals because, what does a mouse seeing God look like anyway? And the response that sort of line of thinking led people to say, so if we're going to really understand the cool parts of psychedelics, we have to give people psychedelics and put them in fMRI brain imaging machines. And then we can look at what brain areas light up and what brain areas stop lighting up under psychedelics and infer some sort of mechanism based on those changes in blood flow to those brain areas. And I found that kind of reasoning somewhat spurious and somewhat unsatisfying to suggest that that's a mechanism, partially because fMRI imaging has its limitations. It's inferring brain activity from blood flow. Its temporal resolution, its spatial resolution is very poor compared to electrophysiology. But more generally speaking, the idea is that if we understand some anatomical locus for where psychedelics are acting, we understand how they work. And the octopus experiment really challenges that whole viewpoint, because an octopus doesn't have a default mode network. It doesn't have an amygdala, it doesn't have a nucleus accumbens, it doesn't have a brain stem. Its brain is so evolutionarily distant from us. We are more closely related to a starfish than we are to an octopus. And yet the animals responded basically in the same way to MDMA as mammals do. And so what that tells us is that the mechanism is at the level of the molecules, because in terms of the binding site of MDMA, that's conserved across octopuses and humans, right? And so the anatomy can be different, but the molecular machinery can use whatever tools are available to it anatomically to get the same behavioral response done. And so what that tells us is that, these studies that say, oh, well, we gave psychedelics and the default mode network, functional connectivity went down. That's an explanation for one way of solving the problem, but it's not the mechanism. It's not really telling us deeply about how this happens. And so this octopus experiment, even though most people think of it as just like, wow, someone gave octopuses MDMA and they hugged each other, right? For me, it's a much deeper philosophical shift in understanding causality, mechanism, and how to think about the brain.
Yeah, and it's led to more experiments and more ideas. And, I know your brain is constantly bubbling with new studies and new
Yeah.
ideas. But
Well,
based
yeah, I
on
will just
this,
say, I just have to say one thing before we move on. Like, this
please.
idea of using an octopus is actually not mine. The first person who proposed that octopus would be a great animal to look at brain mechanisms was J.Z. Young, who was a neuroscientist who actually first characterized the squid giant axon, and then his students, Hodgkin and Huxley, did all of the action potential characterization. But he proposed that after he worked on squid, he switched over to octopus because he said, if we're going to understand how to build complexity from molecules, synapses, and circuits, we need to look at something that is evolutionarily very distant from us, but that also does, complex behaviors, so that we don't get distracted or confused by similarities that are just accidents of evolutionary history, right? And so if we only ever looked at mammals, we might make a certain kind of rule about intelligence. We might say, the more layers your cortex has, the more intelligent you are. And that would be a reasonable rule if we were just narrowly focused on animals that have a cortex. But the rule completely falls apart when you bring in octopuses, because octopuses don't have a cortex, and yet they're much more intelligent than many animals that have several layers of cortex, right? And so this insight he had, we just sort of adapted it to psychedelics. So we were able to prove his point in a dramatic fashion, but it was actually his theory, I don't know, 40, 50 years before we ever did it.
That's so interesting. I love the backstory on everything.
Yeah.
Now, let's switch gears for a second.
Okay.
But something I noticed when the executive order was being signed was just some of the wording and like who was there and who was in the room. And there was a big emphasis on ibogaine. And I know that that's really reaching the forefront as kind of the psychedelic that a lot of us are looking at with a lot of interest right now. As a neuroscientist, what are your thoughts on ibogaine specifically in the general context of, all the other psychedelics we have available?
Yeah, so I'm definitely one of the early sort of ibogaine champions, because our research was one of the first to demonstrate, this comparative, why is ibogaine so special, right? And so we did a comparative study showing that, looking across all psychedelics, and what we showed is that there is a proportionality between the duration of the trip and the duration of the open state of this critical period, right? And so what that means is that, psychedelics like ketamine, which have a very short trip, typically lasting between 30 minutes and 2 hours, the critical period only stays open for about 48 hours. And then by a week, it's closed. MDMA and psilocybin are sort of in the middle. They have trips that last between 3 to 6 hours, and the critical period stays open for 2 weeks. And then there's ibogaine, which has this crazy long trip lasting 36 to 72 hours. And it keeps the critical period open longer than any other psychedelic that we looked at. And we only measured out to a month, but it's open for at least a month after the ibogaine acute effects have worn off. And so what that tells us is that maybe the reason why so many people are essentially risking their lives, because ibogaine does have cardiotoxicity, as you well know, and we can talk about that more. But despite this risk, and despite the extremely long trip and how difficult it is for people are going down to Mexico and other places where ibogaine doesn't have the same legal status as it has in the US, and receiving this treatment for heroin addiction, for severe PTSD, for depression. And I think that the way that I would explain it based on our sort of observations about the critical period is that this extra long open state of the critical period is an extra long window of opportunity to change those behaviors and those memories and learn a new way of relating to themselves, to the drug. And it's just that extra long window to really help with entrenched memories like heroin addiction, like severe PTSD. So I am definitely very excited about the ibogaine piece of it. And I think my favorite part of the executive order is that they just called them psychedelics, including ibogaine, is what they said. And to me, that's a big shift, right? Because the last 20, 30 years, people have been playing all these word games like rebranding psychedelics with names that are esoteric and deliberately obscuring their relationship to psychedelics because people thought the political backlash against anything called a psychedelic was so severe that, the best way to move things forward would be to call them, entheogens or entactogens, or, talk about the dissociative, whatever, just renaming them lots and lots of different things. And to me, this executive order just cut through all of that. And it said, no, these are psychedelics and we're on board. And we are including, there are some people who were trying to say, oh, ibogaine isn't even a psychedelic, it's an oneirogen. And it's like, no, it's an oneirogenic psychedelic, just like ketamine is a dissociative psychedelic and MDMA is an empathogenic psychedelic. These are just describing some of the nuanced differences in their acute subjective effects, but as a category, they are still all psychedelics. And so my favorite part of the executive order is that it just called a spade, and we're just done with the era of having to play semantic games in order to get this drug class approved.
And I love that because it's like, wait, which word means what and what are we saying? And the general public is not going to understand that. Just talking about psychedelics is a big deal. So let's not make it more complicated than it is.
Yeah.
And I think it's going to give people also kind of just a little bit more leeway to say, yes, I will teach my students, let's say in medical school, about psychedelics or get more involved in research, or it's not a carte blanche, but it's like a little bit more permission. Like it's okay to talk about this topic now.
Yeah. Yeah. It's great. I will say the one thing that, as excited as I am that things are moving forward quickly, I also think that this is an incredibly important moment to make sure that we are educating people about what they are and what they are not, right? And so I'm very nervous around the sort of magic pill kind of language that gets thrown around a lot. And the reason is because translational neuroscience has been fascinated with the whole possibility that we might have a magic pill to cure all diseases ever since penicillin cured neurosyphilis, right? And so in the 1940s, neurosyphilis was like a major cause of dementia, psychosis, memory loss, neuropsychiatric illness. And then this antibiotic comes along, people take it, and boom, they're like cured with one pill, right? And so ever since that time, neuroscience has been dreaming of that. And what that has led to is what we have now as the dominant model of neuropsychiatric disease, which is that it's all biochemical imbalance, right? So there's a biochemical imbalance in serotonin, makes you depressed. And so all we have to do to cure your depression is to give you a selective serotonin reuptake inhibitor, an SSRI like Prozac, and your depression is cured. And this model has essentially dominated medicine and psychiatry since the 1950s. And so I think that the way that a lot of the drug companies are seeing psychedelics is just, oh, these are next gen SSRIs. And I hate that because to me, the clinical evidence around psychedelics really says, no, they're working in a different way than SSRIs. So for example, you can't take a psychedelic under anesthesia and cure your depression, right? You actually have to have the psychedelic experience, and you have to have it in the right context, or what Timothy Leary called the right set and setting, meaning the mindset or the situational setting. And so if you take MDMA and you go to a rave, you're not going to cure your PTSD. But if you take MDMA and you have a meaningful therapeutic clinical interaction that is, pairing MDMA with therapy of some kind, then you're going to get these remarkable durable effects, right? That last for months to years after, 1, 2, or 3 doses, in contrast to SSRIs, which you have to take every day. And when you try and come off of them, your depression comes back, symptoms come back, right? And so it's just treating symptoms, but not addressing root causes. And so for me, the biochemical imbalance model does not explain either the transdiagnostic efficacy, so why are these drugs working for so many different neuropsychiatric diseases, the context dependence, so this fact that you can't use MDMA at a rave and cure your PTSD, and then the durability, right? The fact that when you pair these drugs with therapy of some kind, then you get these durable effects that last sometimes for years. And so I think that the critical period explanation really offers a different way of seeing this, and I'm calling that the learning model, which is that what psychedelics do, they're not the therapy itself, they're instead the ability, the drug that makes the therapy actually work better because it enables learning again. And so it restores the ability to learn to what it was when you were a child. And that restored learning is responsible for the durability. So if you reconfigure those memories, that can be permanent. And then whatever learning context you provide can give you different therapy for different diseases, different contexts for learning. And so that's how I think of it. Unfortunately, I think we've got a long way to go to educate all of the clinicians that this is not just an SSRI 2.0, that really the therapy matters and that they can't prescribe these medicines or think of them like SSRIs. And so while I'm very excited that things are moving forward and that this is a real moment of change, I feel nervous about doing enough of the education piece that we need to make sure that the doctors who are going to be ultimately providing this care know what they're doing and understand how they work.
Yes, definitely. And I like that you mentioned that the trip effect itself is important because there are also a lot of companies out there that are trying to make these tripless psychedelics.
Yeah. Yeah. So I think that the relationship between the duration of the trip and the duration of the open state of the critical period really argues that the trip matters and that these tripless psychedelics are essentially taking a drug that works really well and then breaking them a little bit, making novel compounds that can be patented and trying to rush to get approval. My worry about this is that when you do a clinical trial for something like this, the bar is so low, right? Like even if you get 10% efficacy, you can call it a win and say, look, my novel LSD derivative or my novel ibogaine derivative, look, it doesn't have a trip, and I got a 10% improvement in PTSD symptoms. And so people will sort of overlook the fact that the psychedelic that has the trip gave you a twofold improvement as opposed to, right, just a meager 10%,
Yeah.
right? And so the drug companies will call that a win, but in terms of what works best for people, it's a loss, right? Because we want the thing that works the best, not something that barely squeaks by. And so I think that it's not just the companies that are making tripless psychedelics that are playing this game. I think even some of the other companies who are acknowledging, who are using the old psychedelics, the original psychedelics, they are trying to minimize the therapy because they see that as a way of doing an end run on the FDA sort of requirement for, FDA basically has signaled that they don't regulate therapy, and therefore this is a problem that they haven't defined therapy, blah, blah, blah. And I just think that that's nonsense. And whoever at the FDA is making that claim, I would love to have a conversation with them about this, because to me, this is the difference between psychiatry and neurology, right? Like a neurologist would never say to a stroke patient, for example, we removed your blood clot after your stroke, but we're sorry, FDA just doesn't regulate physical therapy. So you go on home. We don't need the physical therapy. Like, that's just ludicrous. It would never happen, right? And so I think that some of this is just a difference in culture between, or rather, I think it's a difference in what psychiatry has accepted as a reasonable solution to the mental health crisis. Is that bar is so low compared to what would be acceptable in any other branch of medicine. I think that part of the reason that we're so excited to be doing these stroke studies is because if we can demonstrate the same principles apply to motor learning as to neuropsychiatric learning, then I think it will help us to make that sea change from the way that people think about psychiatry to be more like the way that people think about neurology or any other field of medicine.
You just casually mentioned it, but yeah, your team is recruiting for a new study.
Yep.
I don't know if you're able to talk about it at all, but we just started, right?
Yeah. So it's called the PHATHOM trial, PHATHOM, and that stands for Psychedelic Healing Adjunct Therapy Harnessing Open Malleability. I know it's a complicated acronym, but it just came to me in a dream. And I just love it because it's, taking something that's unfathomable and making it fathomable again. And also because of the allusion to sort of fathoms deep, and, the
Sounds great.
video game that we're pairing it with is a dolphin video game. So the patients play this video game, and as they move their arm around, a dolphin swims around and catches fish. And so that sort of dolphin metaphor fit nicely with how we were thinking about this. And so the idea is that after you have a stroke, there is a window of about 2 months where the critical period for motor learning reopens, and whatever therapy you get within that first 2 months of having the stroke, that's your best chance at recovery. And if you don't get it, you don't get enough, or other things are going on that make it impossible for you to start doing the motor, the other motor therapy, that's kind of it. And you're locked into whatever amount of recovery that you got. So there's a huge number of patients. I mean, we're talking like hundreds of thousands of people every year in the United States alone who, that critical period closes and they have not recovered full range of motion, full strength, full fluidity of their motions. And so they're desperate to find something. And so we are taking the bold idea that we are going to take all of those patients, those chronic stroke patients who had a stroke over a year ago, and we're going to use psychedelics to reopen this motor critical period and give them that intensive physical therapy and occupational therapy that they need to get to that recovery state. So that's our trial. And we just finished dosing our 4th patient, and we are still actively recruiting more patients.
Great. And it's happening in Baltimore. So if anybody's in that area and you think, you or your family member could be in the trial, go to the website. That's going to be really interesting to just see what happens when that study comes out. So I look forward to reading the paper when it's all done.
Yes. All right. Well, I'm super excited about it. It feels like a really momentous thing because it will be amazing for all of the stroke patients themselves, but then also I think it will really shift the conversation about psychedelics and help us to better understand this relationship to learning.
Yes. Well, thank you for all of your insights. I can't wait for, the future directions of your research and all the great things we're going to find out.
All right. Well, thank you. And it's so nice to be on your podcast.
Come back anytime. Please like, subscribe, share, and download the podcast. And again, you can find us at Human School Podcast on Instagram. I'd like to thank Dr. Zac Efron for the theme music. And I'd just like to make a general disclaimer that any of the institutions I work for, including Community Regional Medical Center, UCSF Fresno, and American Ambulance, have nothing to do with any of my thoughts or opinions, and so we'll kindly leave them out of this. Thanks, everyone. See you next time.